So I'm pleased to introduce the 8th annual Jay and Margie Grosfeld Lecture. Both Jay and Margie are dear friends to APSA. They can usually be seen together. Dr. Grosfeld was president of APSA from 1994 to 1995. You all know how many esteemed positions he's held as president of the American Board of Surgery, president of the American Surgical Association, and continuing on as the incredible editor of the Journal of Pediatric Surgery. And it is particularly appropriate that a friend recognized him by naming this lecture in their honor. Jay was the origin of my favorite comment about so many people in the audience. He's one of those people who has done more in an afternoon than I hope to do in my career. And our Jay and Margie Grosfeld lecturer this year is certainly a similar person. Henri R was born in Port-au-Prince, Haiti. Jeff Upperman has already referred to that. Moved to Brooklyn at 13 years old, where there was a Haitian community. Got his bachelor's degree at Princeton, went to medical school at Harvard, and did his residency at the New York Hospital. He did research and his pediatric surgery fellowship in Pittsburgh, and rose in the ranks of the faculty to become the Benjamin Fisher Chair and Surgeon-in-Chief at the Children's Hospital in Pittsburgh, which would be more than enough for any of us, but not for Henri. So in 2005, he was recruited to the Keck School of Medicine at the University of Southern California, where he is Vice Dean of Medical Education, Professor and Vice Chair of Clinical Affairs in the Department of Surgery, as well as Vice President and Surgeon-in-Chief at the Children's Hospital of Los Angeles. He's a governor and regent of the American College of Surgeons. He's been an APSA governor. He's been president of the Academic Surgeons Association, and he's a permanent member of the Anesthesiology, Surgery, and Trauma Study Section. This just tells you the things that I think are important. Having said all that, do I have to tell you that he is continually funded in basic science research, that he might be well published and a member of a few organizations? I think the outstanding feature of Henri is he is the possessor of the most continuous and engaging smile I know. Today, he's going to address us on his insights into the pathogenesis of necrotizing enterocolitis and the role of intestinal microbiota.
Thank you so very much for that generous introduction, Mr. President. I have no relevant financial relationships, no disclosures, but I will be speaking about investigational drug, VX-765. It is truly a singular honor for me to stand in front of you today on this podium to deliver what I think is one of the most prestigious lectures certainly I've ever been associated with. That's the Jay and Margie Grosfeld Lecture. These are people that I hold in highest esteem, and to be asked to give this particular talk is quite humbling. Certainly makes me quite nervous. I don't remember the last time I was really nervous standing up in front of an audience, but this one brings a whole lot of trepidation. And Jay and Margie, thank you for all that you've done for pediatric surgery, and thank you for continuing to stimulate all of us. I also want to recognize and acknowledge my friend, mentor, teacher, Dr. Schamberger, because he initiated this process several years ago, but I was not able to deliver, but I love you nonetheless. And my client, thank you so very much for bringing me here today. What I'm going to do is share with you some insights that we've developed into the pathogenesis of NEC over the past 20 plus years that have been studying this vexing problem. And this is the outline. We're going to review the origins and the role of nitric oxide in the pathogenesis of NEC, and we will conclude by looking at the role of some of the opportunistic pathogens in the development of this vexing problem. This audience knows it too well. NEC is the most common and the most lethal disease that affects the GI tract of premature infants. The mortality is high, unacceptably high, and it continues to frustrate us because in the kids who are affected by the most severe form of the disease, it approaches 100%. And unfortunately, the incidence of NEC is continuing to rise as a result of advances in neonatology that have shifted the LD50 from 28 weeks to the point where now we know that infants born at 23+ week gestation are routinely surviving and thus are at increased risk of developing NEC. For those of you who are 45 or younger in the audience, this is Mark Rowe, arguably one of the most brilliant pediatric surgeons that I know. Dr. Rowe is my former teacher, a training director, mentor, colleague, and friend. He is arguably viewed as the father of pediatric surgical critical care. He was a very creative and innovative surgeon who was always interested in NEC and would come up with new surgical approaches to try to deal with this vexing problem. But yet, despite his technical ingenuity, as a fellow, I recognize that these infants just died just the same, despite how brilliant that operation was. So as I completed my training, I came to recognize that NEC is truly a systemic disease that is associated with a high mortality rate, regardless whether you use aggressive surgical or medical therapy. So when I became a young attending, I decided to study why and how NEC evolves. But first I had to acquire a fairly thorough understanding of the factors that regulate the intestinal barrier failure in the neonate as measured by bacterial translocation. So in our first study, we were able to demonstrate that the intestinal microbiota plays a crucial role in the process of bacterial translocation. In essence, gram-negative bacteria were required for the development of bacterial translocation. If you did not have gram-negative bacteria, you did not get translocation. Later on, Don Sorrells, now a pediatric surgeon, was able to show that it is the gram-negative bacterial cell wall component, endotoxin, that was responsible for actually mediating bacterial translocation. And then the toxin did so by inducing the production of nitric oxide, because if you block nitric oxide production, you're essentially able to abrogate bacterial translocation. But we should stop for a second to talk about nitric oxide. But nitric oxide itself is a fairly innocuous molecule, but it plays a paradoxical role in intestinal physiology. Low levels of NO that are produced by the constitutive isoform of the enzyme are actually protective and can enhance mucosal blood flow and regulate intestinal epithelial permeability. However, high levels of NO that are produced by the inducible isoform of nitric oxide synthase as a result of an inflammation can be fairly harmful and can lead to bacterial translocation. But since NO is fairly innocuous, most of the cytopathic effects of nitric oxide are mediated by this molecule, peroxynitrite, which is formed by the reaction of NO with superoxide. So the question we asked, therefore, was, does NO and its adduct play a role in human NEC? So as a young attending, we started collecting all of the specimens for infants who are undergoing bowel resection for acute NEC, whether it was 1 in the morning or whatever time it was. And then we looked for evidence of iNOS protein and mRNA and protein in the intestine of those infants who were undergoing bowel resection. And what we found was that indeed iNOS, mRNA, and protein were upregulated in the villi in the presence of these of the protein and messenger RNA co-localized with areas of cellular injury where cells were dying by apoptosis. Well, since NO doesn't cause damage, it's peroxynitrite that does so, we needed to know whether or not peroxynitrite was being generated. But there is no direct way to measure peroxynitrite in the tissues. But we know that we can get indirect evidence that peroxynitrite was generated by looking at immunoreactivity to 3-nitrotyrosine, because peroxynitrite has one purpose in life, which is to nitrate tyrosine residues in proteins. So when we looked for immunoreactivity to 3-nitrotyrosine, we found that indeed there was robust staining in the villi in the presence of the nitrotyrosine staining also colocalized with areas of epithelial injury, thus suggesting to us that epithelial injury was being mediated by the generation of peroxynitrite. And more importantly, at the time of intestinal stomach closure, when the infant had completely recovered from acute NEC, what we found was that iNOS levels were actually back down to baseline, thus establishing the association between upregulation of iNOS and the development of acute NEC. But to really begin to dissect the mechanism by which NO and its adduct were playing a role in the pathogenesis of NEC, we needed to develop a suitable experimental model. So we went back in time and adopted a model that was previously described by another pediatric surgeon among us, Dr. Barbara Barlow, where we take pregnant rats, we induce them at term, and then subject them to hypoxia and formula feeding. Let me digress for a second to say that back in the days when Dr. Barlow was doing this experiment, she was putting these animals in a plastic bag, put them in a pocket, and continue on rounds. So that was the form of hypoxia. But we have progressed over time. Ladies and gentlemen, we have progressed over time. We have a hypoxic chamber where we can actually modulate the amount of nitrogen and oxygen that we deliver. But anyway, the controls are left with the mothers, and they don't receive a hypoxic insult, and then the rats are sacrificed on various days. And NEC is then confirmed by a pathologist who is blinded to the groups. And this is some of the work that Evan Nadler did when he was with us in the lab. And it shows a scanning electron micrograph that illustrates the normal villus architecture of the breastfed neonate compared to the distorted architecture of the formula-fed hypoxic animal that develops NEC. And these arrows demonstrate cells that are undergoing apoptosis, and this is not really viewed in the breastfed. Next, we perform full-color immunofluorescence looking at apoptosis, proliferation, iNOS, and nitrotyrosine immunostaining in our experimental model. Let's focus on the panel A, which is from the formula-fed hypoxic animal. What we can see is that there is extensive inflammation, there is distortion of the villus architecture, so that what we see now is just a bunch of ghost villi that are left. When you look at iNOS immunostaining in green, we see that there is robust staining in some of those residual ghost villi. And when we look at apoptosis measured by the Tunnel assay in red, there are quite a few cells that are undergoing apoptosis in the formula-fed hypoxic animal. The insert shows colocalization of iNOS and apoptosis, thus suggesting that in this experimental model, the generation of iNOS may be associated with intestinal inflammation. And when we looked at proliferation using the proliferating cell nuclear antigen, which is depicted by those fine yellow arrows, we see that there are very few cells that are proliferating in the formula-fed hypoxic animal, in contrast to the breastfed animals, where we see quite a few proliferating cells, a paucity of cells undergoing apoptosis, and essentially no detectable iNOS. Since it's nitrotyrosine, that's the peroxynitrite that's actually mediating epithelial injury, we look for immunoreactivity to 3-nitrotyrosine, and again, it's easily detected in the formula-fed hypoxic animals, where we also see, again, apoptosis, but undetectable in the breastfed animals. Thus telling us that the observations made in the human were essentially reproduced in this experimental model. But we should digress for a second to consider the factors that influence intestinal barrier function. Really, intestinal barrier function hinges on the dynamic equilibrium between tissue injury and tissue repair. Now, we've already established that LPS induces iNOS, which in turn leads to the production of NO, reacts with superoxide to make peroxynitrite, which causes epithelial injury. But once there is a breakdown in the epithelium, the repair mechanisms are activated in order to restore the integrity of the intestinal epithelium. Those repair mechanisms consist of enterocyte migration and enterocyte proliferation. If those repair mechanisms are not activated, as you sit down here this morning listening to this boring talk, you would be showered by bacteria. So we had to revise our hypothesis to state that in order for peroxynitrite to cause gut barrier failure, not only must it cause epithelial injury, apoptosis, but peroxynitrite must also suppress the repair mechanisms, namely enterocyte proliferation and migration, in order for you to have that persistent defect So we have already seen that from this, we've already seen previously that proliferation is impaired in our experimental model. So the next question we asked was, what about enterocyte migration? Is it also impaired? And this is a question that we were able to answer in conjunction with Dr. David Hackam when we were working together in Pittsburgh. In this brilliant experiment, David injected BRDU to breastfed or hypoxia and formula-fed animals. BRDU is a marker that will incorporate in the DNA or nucleus of dividing cells, and you give it at 1 hour, and then after 18 hours, you give an antibody to BRDU, and then you measure how far the marker has traveled along the crypt-to-villus axis over that time. And this is graphically illustrated here. This is how far the marker traveled in the breastfed animals, but in the NEC animals, those that receive hypoxia and formula feeding, we see that migration is actually suppressed in vivo. To try to address the underlying mechanisms responsible for this, we had to use a reductionist approach, whereby David plated IEC6 cells, which was right intestinal epithelial cell line, on a cover slip, allowed the cells to reach confluence, and then inflicted a standard wound using the cell scraper here, and then used live cell microscopy to measure how long it takes to actually restore the integrity of the epithelium, of epithelial monolayer. And this is really the control setting. In the presence of a nitric oxide donor, here's what happens. You have your initial defect right here, but we can see that even after 24 hours, you fail to restore epithelial integrity, thus confirming for us that NO inhibits enterocyte migration in vitro as well. This is graphically illustrated here. This is your control migration, and this is what happens in the presence of the nitric oxide donor. So now, having established that NO, or nitric oxide, is really important for the pathogenesis of NEC, the question we had to ask then is, does iNOS deficiency prevent the development of experimental NEC? To answer this question, we exposed iNOS deficient mice in the congenic wild-type strain to formula feeding and hypoxia, and then we measured the degree of intestinal inflammation. As predicted, the wild-type animals developed significant intestinal inflammation, but the iNOS knockout animals showed a marked decrease in the amount of intestinal inflammation detected. So suggesting that indeed iNOS deficiency does protect against the development of NEC. So if iNOS is important for the pathogenesis of NEC, understanding the factors that regulate iNOS production may be very important in order to develop effective therapeutic strategies to combat this vexing problem. So what we have here is a schematic illustration of the transcription factors that may regulate iNOS gene transcription. We know that STAT1 and NF-kappa-B act as transcriptional activators, whereas AP1 acts as a transcriptional suppressor that really binds to the promoter and prevents the activators from inducing iNOS gene transcription. And we know that inflammatory mediators will act on those various transcription factors to regulate iNOS gene transcription. So the question is, which inflammatory mediators are present or active in our experimental model? So we started to look in conjunction with Dr. Upperman for all of the various inflammatory cytokines that may be produced in the setting of experimental NEC. So we looked in the intestinal segments for a battery of various inflammatory mediators. But what we found was that of all the cytokines tested, only IL-1 beta was most prominently elevated. And IL-1 beta peaked around day 3 and remained elevated on day 4 when compared to the breastfed animals that did not develop intestinal inflammation. IL-1 is normally secreted in a precursor form that must be cleaved by IL-1 converting enzyme, also known as caspase-1, in order to secrete the biologically active product IL-1 beta. So we asked the question, is IL-1 converting enzyme, or caspase-1, present in human NEC? And here we use a fluorescent antibody to caspase-1, which is in green, and then the blue is the DAPI, which stains the nuclei. What we see is that there is robust caspase-1 activation in human NEC. In contrast, an infant with ileal atresia, there is no caspase-1 activation detected. The same is true for our experimental model. On day 0, whether it's breastfed or formula-fed animals, there is really no detectable caspase-1 activity. But by day 4, in the formula-fed hypoxic animal, we see that there is abundant caspase-1 activity, and this is virtually undetected in the breastfed animals that does not have inflammation. Caspase-1 is also secreted in precursor form, so we look at procaspase-1, caspase-1, IL-1 beta precursors in our experimental model, and focus here on the formula-fed hypoxic animals. And we look at procaspase-1 activity. Again, it's markedly increased in the formula-fed hypoxic animal, as is caspase-1 itself, in contrast to the breastfed animals where it's really not as much. When you look at IL-1 beta precursors, we see a twofold increase in the transcripts of the IL-1 beta precursors in the formula-fed hypoxic animal when compared to the breastfed animal when normalized for the housekeeping gene, ribosomal protein 13. So if both IL-1 and iNOS appear to be important for the pathogenesis of NEC, the question we asked was, is there a relationship between them? Stated otherwise, does IL-1 induce iNOS? So we looked at a host of inflammatory cytokines for their ability to induce iNOS protein. We looked at them either alone or in combination. What we see is that only IL-1 beta was able to induce iNOS by itself. TNF-alpha couldn't do it, interferon gamma couldn't do it, LPS could not do it by itself. But if you add those 3 cytokines together, we see that there is a synergistic increase in the amount of iNOS protein that was generated. Interestingly, any combination that included IL-1 resulted in an increase in the amount of iNOS being generated. But the combinations that lacked IL-1 showed no increase in iNOS, in fact, no detectable iNOS activity, thus establishing that IL-1 was required for iNOS gene transcription. So going back to our schematic illustration, how is it that IL-1, TNF-alpha, and interferon gamma work on these transcription factors to promote gene transcription? So we had to look at their effects on those various transcription factors. And here we're looking at the effect of IL-1 beta on NF-kappa B and STAT1. Expose IEC6 cells to IL-1 beta, and what we see is that within 15 minutes, NF-kappa B is activated. In contrast, there is no effect on STAT1 activation. Is NF-kappa B required for iNOS gene transcription? Here we use inhibitors of NF-kappa B, and we see that in the presence of the inhibitors, there is no iNOS gene transcription. So IL-1 is inducing NF-kappa B, and NF-kappa B appears to be required for iNOS gene transcription. Well, what about the AP1 transcription factor? And here we look at the effect of TNF-alpha as well as IL-1 beta, both on NF-kappa B and AP1. Going back, so here we're able to establish that just like IL-1 beta, TNF-alpha is able to induce or activation of NF-kappa B. But when you look at what happens to AP1, it starts out here. There is really no effect at all by TNF-alpha on AP1 transcriptional suppressor. But let's look at what happens for IL-1 beta. This is where we start. But over time, by 4 hours, we see that there is disintegration of the AP1 transcription factor. What about interferon gamma? We look at this effect on STAT1, and we can see that within about 15 to 30 minutes, it's phosphorylated, so it's activated by interferon gamma. But interferon gamma actually had no effect on NF-kappa B or on had no effect on NF-kappa B. So how does it all work? And here's what we propose. IL-1 will actually lead to the dissociation of AP1 from the IL-1 iNOS promoter, and also will lead to the activation of NF-kappa B, allowing it to bind to the promoter, leading to iNOS gene transcription. TNF-alpha is also going to activate NF-kappa B, leading to further increase in iNOS generation, whereas interferon gamma will actually activate STAT1, which again would lead to synergistic increase in iNOS gene transcription. But in the absence of IL-1 beta, interferon gamma and NF-kappa B cannot actually bind to iNOS, to the iNOS promoter to lead to gene transcription because IL-1 is required to relieve the suppression mediated by AP1. So if IL-1 is required now for iNOS gene transcription, does IL-1 receptor deficiency prevent or attenuate the development of experimental NEC? And to answer this question, we exposed IL-1 deficient animals as well as TNF deficient animals in a congenic wild-type strain to the formula feeding-hypoxia regimen, and then we looked at the degree of intestinal inflammation. Wild types, again, develop significant inflammation, and surprisingly, even the TNF-alpha animals or knockouts actually develop intestinal inflammation. But look at what happens to the IL-1 receptor knockouts. They are all protected from the development of experimental NEC. And that's because in the case of TNF-alpha, they have competent IL-1 to relieve the AP1 suppression that will lead to gene transduction in iNOS production. So when you look at, just for the micrograph is H&E stain, some segment of intestinal epithelium from wild-type animals here, IL-1 receptor knockout, and iNOS receptor knockout mice. In the wild type, there's quite a bit of intestinal inflammation. There is loss of the villus architecture. In contrast, IL-1 receptor knockout, iNOS knockout animals, the villus architecture is protected. When we look at junctional associated molecule A, which is really a measure of tight junction integrity, because this molecule binds to the tight junctions between the cells, we see that in normal healthy tissue, you can see there is robust staining between the cells. Which is the case for IL-1 receptor knockout and as well as iNOS knockout animals. But in contrast, in the wild-type animals, which, as we know, have gut barrier failure, this protein JAM-A is actually internalized and redistributed across the cytoplasm and simply not seen quite where it belongs between the tight junctions. What about the effect of IL-1 receptor deficiency on iNOS production and apoptosis? And here, this is an immunofluorescent stain for iNOS in red. The DAPI sends the nuclei in blue. In the wild-type animal, again, quite robust immunostaining for iNOS, but virtually much less of that in IL-1 receptor knockouts and undetected in the iNOS deficient animals, as we would expect. When we look at apoptosis using a fluorescent pan-caspase inhibitor, again, in the wild-type animals, quite a few cells are undergoing programmed cell death or apoptosis, whereas in IL-1 receptor knockout and iNOS deficient animals, we see very few cells that are undergoing apoptosis. Well, the next question we asked was whether or not a caspase-1 inhibitor could ameliorate the intestinal inflammation in our experimental model. One of the problems that we have with existing caspase inhibitors is that they are peptides, and so once they get into the stomach, they are digested, and so they can never actually reach the desired targets in the epithelium. So this compound is actually a non-peptide inhibitor, which tries to bypass this limitation. And here we can see that if you give this compound, you suppress IL-1 beta generation, whereas the animals that received the vehicle had IL-1 beta's generation very reminiscent of what we saw before. If you give the vehicle, you can see the degree of intestinal inflammation, so these animals get NEC, but when these animals actually receive the compound, we see that they are protected from the development of intestinal inflammation. So yes, it does work. What about iNOS induction? You give the vehicle, we can see that there is normal iNOS induction in the intestine, but if you give the drug, we can see that iNOS induction is actually suppressed. And lastly, we looked at gut barrier failure. We looked at the passage, a transmucosal passage of Texas red dextran, which is a fairly large molecule that normally does not cross the epithelial barrier. We looked at its passage after receiving the drug. And this is the baseline passage in the breastfed animals that have a normal gut barrier. If you subject the animals to formula feeding-hypoxia, you basically triple the passage of Texas red. But if the animals receive VX, if you pre-treat them, we can see that you suppress the gut barrier dysfunction, so that it's almost as the similar level that's passing in the breastfed animal. So yes, it actually protects against the development of gut barrier dysfunction. So to summarize this first part, what we have shown thus far, LPS induces inflammatory cytokines, particularly IL-1 beta. And IL-1 is responsible for inducing iNOS, which in turn leads to the generation of NO. NO will react with superoxide to produce peroxynitrite, which in turn will mediate a gut barrier failure by causing epithelial injury and by suppressing the repair mechanisms. And we've demonstrated that caspase-1 inhibition can prevent gut barrier failure in NEC. For the remainder of this talk, we wanted to focus on the role of opportunistic pathogens in the pathogenesis of NEC. So really going back full circle, because as you recall, the first observation we made was that the intestinal microbiota plays an important role in the development of gut barrier failure as measured by bacterial translocation. That was the very, very first study that we came up with. But it is clear that the intestinal microbiota also plays a critical role in the pathogenesis of NEC. Why? Because germ-free mice simply do not develop NEC. Bacterial colonization is required. So this observation has led investigators over the past few decades to focus on the possibility that there are specific organisms that may be associated with the development of NEC. But unfortunately, these studies have been inconclusive because they're kind of all over the park. They've used both microbiological techniques as well as molecular probes to try to characterize the microbiota, but with inconsistent findings. Some studies have reported higher occurrence of proteobacteria in NEC. Others report there is decreased species diversity in NEC. And others still say that you have the same bacterial species in NEC patients as we see in healthy individuals, so does it really matter? Is there a specific bacteria that's really associated with NEC? Well, there is no question that NEC is an infectious disease. There have been a plethora of organisms that have been implicated in its pathogenesis. Both bacteria, viruses, and fungi, all of them seem to play some role. So we started to ask ourselves, is it possible, therefore, that since NEC occurs early in neonatal life, is it possible that the nature of the first colonizers, the organism that first get there, will determine whether or not the patient will develop intestinal inflammation? i.e., is this process of intestinal inflammation the result of the virulence of that particular first colonizer to be tested? Well, why is that plausible? Well, look at the diversity of the first colonizers. The most common first colonizers are human commensals, E. coli, Enterococcus, and so forth. Then you have other human commensals that tend to be more pathogenic, but you can also be colonized by domestic animal commensals, plant bacteria, soil, and water bacteria. So it may be a race for who gets there first. And why is that possible? Well, consider the intestinal microbiota in the neonate versus the adult. In the adult, the microbiota is quite complex. You have over 1,000 species. In the neonate, it's very simple, 1 to 3 species maximum. In the adult, it's quite uniform. As we sit here, it's pretty much a standard proportion of the various species among us. But in the early stages, in the neonate, quite diverse. And we will show you shortly the amount of diversity that you can find in just 1 liter of bacteria, in 1 liter of rats. And last but not least, the adult stage, things tend to be stable after a week of antibiotics. You basically reestablish your normal microbiota, whereas in the newborn, it tends to be fluid. It's constantly changing. So there is the possibility that a first colonizer could really establish a stronghold and cause epithelial damage. But look at the diversity in 1 liter of rats, right? This is the same liter, 9 rats being treated essentially the same way, being housed the same way, being fed the same way, and with careful precautions made not to introduce exogenous bacteria. But look, at animal 4 and animal 9, there is a 10 to the 4-fold difference in the number of bacteria detected. 1, 4, and 9 are colonized predominantly by Shigella. 2, 3, 5, 6, and 7 are colonized predominantly by this bacterium S191, whereas number 8 is colonized mostly by Enterocolitis faecalis. And folks, this is the same litter, same condition. So we can see that there's a lot of diversity in the newborn. So we started to focus on one model of an opportunistic pathogen, Chronobacter mutensis, which has been implicated in outbreaks of NEC. Dr. Hunter, currently at Lurie Children's, demonstrated when she was with us in the lab that if you add Chronobacter mutensis, which was, as I said, previously known as Sakasaki and so forth, if you add it to the formula, you can exacerbate the degree of intestinal inflammation, the degree of intestinal necrosis, almost to the point where it actually resembles the human condition. Kathy actually labeled the bacteria with a green tag, a green fluorescent protein, and she was able to demonstrate that this bacterium actually attaches to the epithelium, and where it attaches, there is intense intestinal inflammation as evidenced by increased apoptosis when compared to the formula-fed hypoxic animal that did not receive formula supplemented with Chronobacter mutensis. Not surprisingly, the addition of the Chronobacter mutensis led to a more severe histologic grade of NEC. And subsequently, Claudia Imami was able to demonstrate that indeed, Chronobacter mutensis is a very good early colonizer of the neonatal intestine. And this is what happens just over the course of 72 hours. We can see that it's there and it does a pretty good job in the intestine. So we had to stop for a second and ask ourselves, well, are the pathogenic properties of Chronobacter mutensis strain-specific, or are they really species-specific? And to answer this question, we examined 24 different strains of Chronobacter mutensis. These were isolates from various sources, some from the environment, some from dairy products, and also some from human patients. But to summarize, only these 4 isolates that were derived from human patients were able to bind effectively to intestinal epithelial cells. So only these 4 isolates could mediate epithelial injury. None of the other ones could. So which tells us that the pathogenic properties are actually strain-specific, not species-specific. And this observation may begin to explain, in part, why some of these early microbiome studies have been somewhat inconclusive. Because what did we find? Well, we found the same species may be present in infants with acute NEC, also in the same patients, in the same infant, or also in infants who are healthy. So therefore, people were wondering whether or not the bacterial species really made any difference. But what we're seeing here is that it's not the species, but the strain that really matters. So in view of the fact that we see Chronobacter mutensis may be an opportunistic pathogen, we started to ask the question, are there other opportunistic pathogens that may be detected and be associated with the pathogenesis of NEC? So we went back to our model and we subjected newborn rats to formula feeding and hypoxia. We measured the NEC grade in each animal. We characterized the bacterial populations in the individual animals. And then we identified the bacterial strains that are tentatively associated with NEC. Then we test the ability of these strains to promote NEC upon reintroduction to healthy animals. So this is a fulfillment of Koch's postulate. So these are the methods for characterizing bacterial populations. Dr. Lim in the audience has been crucial in all of these experiments. So we use a culture-based approach. We essentially homogenize the intestinal tissue, and then you plate them, and ultimately we find out which bacteria are present. The advantage of this approach is that it's quantitative, but the problem is that you may miss a number of species depending on the rigorousness of your culture techniques. Alternatively, we also use a culture-independent approach that relies on the amplification of 16S ribosomal DNA. But this technique, while it will allow you to capture all the species, it is not quantitative. And as we saw earlier, it's not just the species, it's really the strain within a species that determines the degree of of virulence. So there are limitations to both approaches. But nonetheless, what we've been able to come up with thus far is this weighted NEC grade, which is a tentative measure of a strain's pathogenicity. Let's focus on this quadrant. Here we have identified E. coli Na114. This organism has been detected in 10 animals. In 9 of these animals, they had a grade of 0, so no inflammation. In 1 animal, there was a grade of 1. So the weighted grade is 1/10, or 0.1, which means that it is a low virulent organism. In contrast, E. coli DSM was isolated in 8 animals. In 2 of them, there was a grade of 0, but in 6 of them, there was a grade of 2. So the weighted index is 12/8, or 1.5, which means that it is a virulent organism similar to Chronobacter mutensis that we've already been talking about. In E. coli DI, isolated in 10 animals, 9 of them also no inflammation, 1 of them a grade of 1, so the weighted index is 1/10 of 0.1. So the next step is therefore is to determine whether or not by reintroducing these organisms as first colonizers, we could attenuate the development of intestinal inflammation. But first we use the one with high virulence, DSM. And this is our baseline. The breastfed animals really don't develop much intestinal inflammation. The formula-fed hypoxic animal, we see the degree of intestinal inflammation measured by a score of 2 or higher. If you give DSM, whether 10 to the 5th or 10 to the 7th, we can see that we shift the degree of intestinal inflammation significantly higher, which tells us that indeed, early colonization by this particular strain is associated with the development of more severe intestinal inflammation. Well, let's do the reverse. Let's use one of those low virulent strains and see if colonization with this organism may prevent the development of inflammation. And here we go. So this is, again, our control, the breastfed animal. This is the formula-fed hypoxic animal, the degree of intestinal inflammation detected here. And if you give E. coli strain 69, whether 10 to the 6th or 10 to the 8th, we can see that we're actually able to reduce the degree of intestinal inflammation. So could that be potentially a mechanism by which the probiotics are working? Yes, because there is competition. So what have we shown? What we've told you today is that bacterially induced nitric oxide plays a key role in the pathogenesis of NEC. IL-1 beta is a key inflammatory cytokine that is involved and really plays a crucial role in the pathogenesis of NEC by inducing iNOS. Early bacterial populations clearly are highly diverse. Chronobacter mutensis is one of the few proven NEC pathogens, although we are now beginning to characterize a number of others. Bacterial virulence in NEC may be strain-specific rather than species-specific, very important for our microbiome studies and the implications. And last but not least, random colonization with opportunistic pathogens may explain why some at-risk babies develop NEC while others do not. So to leave you with this current concept regarding the pathogenesis of NEC, so in a premature neonate, who already has a leaky intestinal epithelial barrier, any superimposed insult caused by hypoxia, ischemia of any sort will lead to further derangement of the gut barrier, allowing bacteria to translocate and incite an inflammatory response that will lead to the production of inflammatory mediators, in particular IL-1, which, as we know, will lead to the generation of iNOS, the production of NO, which will react with superoxide to produce more potent peroxynitrite that will cause epithelial injury, systemic sepsis, and all of the attendant sequelae that characterize necrotizing enterocolitis. This is a slide that I've borrowed from my dear friend, Dr. Bogsdale. If you see a turtle sitting on top of a post, so the logical question is, how did it get there? Well, my friends, ladies and gentlemen, I stand on this podium today because of the mentoring, the support, the encouragement that I've received from so many of you in this audience. From the time I was an aspiring young surgery resident in the lab to the time where I became a pediatric surgery fellow. And to this date, I continue to receive a whole lot of support, a whole lot of encouragement from so many of you. And for all of this, I'm eternally grateful. But I'm also grateful for all the people in the audience, many of whom have influenced my life in many ways by teaching me, whether because they were working in my lab or were fellows in my, whether at Pittsburgh or in Children's Hospital of Los Angeles. So I'm eternally grateful to all of you. This is just a partial list of all the people who have contributed to the work that I've presented here today. Some of my collaborators at Children's Hospital of Pittsburgh and those from Children's Hospital of Los Angeles. I know it is not inclusive because so many people have played a pivotal role in this process. Know that I love you just the same, even if your name is not on this list. Thank you very much.
Okay.